everybody must get below 7%, we look at the person and go, man, you're young, you're doing everything right, you're hitting below 7%, you're below 6.5%, you're not having any lows, great, perfect. End of life, 80-year-old, has maybe limited life, maybe we expect 5 to 6 years. Then you raise that goal. So we're going to individualize it, make it less stringent. Okay? Or let's say, like for the patient I told you that had cerebral palsy, that couldn't communicate as well. We kept him out of having lows by raising his A1C up to between 7.5 and 7.9. So that's what that means. And then your before meal goals, 80 to 130, and above, I think, I don't remember for adults, they've changed it. Usually it's about 100 to 140 before bed. Children, 7.5% is the population goal. The goal before a meal is 90 to 130, and before a meal, before bedtime, it's is it 90 to 150? 150 is the top end. Okay, so are those population goals. That is what addresses that objective. Is that clear? Other questions along that line? Those of you who are working on the objectives as we go. Oh, we're like machines. When I was when we were in the PharmD program at Texas, we took the medical school curriculum. And I never saw a group so organized as the medical class that we were with. In terms of note-taking, they were superstars. It was just amazing. They just kind of plugged you in, you just kind of went with the machine. It was good. So managing, because there were no handouts, nothing. So you had to sit there and take notes. So we would have a scribe, and then we would have somebody who would transcribe that, and then somebody who packaged it and got it out to everybody. It was a great machine. I love the guy that I was paired with. He was an artist. So I would write the note out, and then he would write all these great little, create all these great little pictures along the side. Some of them had something related to medicine, and some of them had nothing related to medicine, so they were great. So you all are like machines. To manage the amount of material you get, I think is incredible what you do. It's interesting to watch. So classes are different. Les class didn't do anything like what you all, they didn't approach it like you did. It's interesting. Just an observation. Okay, so complications. So monitoring, screening and monitoring for complications is the next big piece of managing patients with diabetes. Because these are the things that affect their morbidity and their mortality, their quality of life, length of life. Okay? So these are really important. These are the things that the insurance companies will grade you on. If your group only does about 30 to 35% screening for retinopathies, they will come after you. They'll give you a report card. They'll publish it on a website and tell people this group doesn't do diabetes care very well at all. They won't say that, but they'll start to compare you to different groups. So, is that the reason to do it? No, the reason to do it is because these have been demonstrated that if you do them, if you meet them, you will improve outcomes. So that's the important part. Your patients will be diagnosed with retinopathy sooner. They will get treatment sooner. Their kidneys you will discover nephropathy earlier and preserve them for longer. That's the important part. That's why we do it. So a lot of these are in the initial stage. If you catch them, you can decrease their risk of going on and progressing, or you can prevent them from having them at all. Very important. Okay. So I did you kind of a very brief outline on the second page. Microvascular complications. So what are the microvascular complications? There's three big ones. Retinopathy, nephropathy, neuropathy. And macrovascular are centered around what organ? Heart. Okay. So these are the interventions that have been shown to prevent or decrease risk. So preventing retinopathy is optimizing glycemic control and blood pressure control. Preventing nephropathy, optimizing glycemic and blood pressure control using an ACE inhibitor. Decreasing risk of neuropathy and its sequelae. Glycemic control, smoking cessation, routine foot exam. The #1 preventative intervention to decrease amputation is looking at your feet every day. Patients are taught how to do good foot care, and then you, as providers, looking at them and addressing any problems early on. Macrovascular. So you see the microvascular, they are about glycemic control. That's why it is so important. These come out of that DCCT. So these have now been around for 20, 25 years. Macrovascular. With the heart, it's more than sugar. So just because you normalize somebody's sugar, if you don't address all the other cardiovascular risks, you don't lower their risk as well, to the same extent. So control blood pressure. Reduce cholesterol and triglycerides. Use aspirin as appropriate. And get them to quit smoking, or encourage them. Encourage them. Okay, so let's look at retinopathy. #1 cause of new onset blindness in the United States is retinopathy due to diabetes. So there's two types. There's benign proliferative retinopathy and there is proliferative retinopathy. So benign tells you the word, doesn't usually cause us much trouble. It's characterized by increased vascular permeability, and the other is characterized or more advanced by vascular closure, or you lose that blood supply. Proliferative retinopathy is the more serious, and what happens here is that as that tissue is impacted by blood pressure, smoking, high blood sugars, those little blood vessels begin to weaken. So you may see aneurysms, you may see cotton wool type of, what do they call that, a cotton wool exudate. You may see yellow exudates, that's lipids. You may see bleeding into the eye. All of those are due to the fragility of those little blood vessels. So what happens is you lose those blood vessels, you lose the ability to deliver oxygen to the tissue. So what does the eye do? It makes more blood vessels. And it proliferates them. That's why you get the retinopathy. You start making lots of little blood vessels. And they crisscross all over the retina. And they're not as good quality as what you were born with. They're weak. And so they may bleed. You may make so many of them, you start blocking out vision. Okay. So that's why that's why that eye exam is important every year. So people with diabetes should have a retinopathy scan every year. Send them to an eye person who specializes in diabetic retinopathy. Pete McGee is the best place in the state. They're excellent. But there's lots of excellent people everywhere. But find those that deal with diabetics. So that's the problem with those proliferative retinopathy. So guidelines for screenings. Start with type 2s, they're the easiest. When you see a person with type 2 for the first time, if you diagnose them or you're seeing them for the first time and maybe no one has done these other things, that day write your referral to the ophthalmologist for retinopathy screening. Why do we do that? Why can't we wait? What if they're due onset? Never known to have it before. Their blood sugars are maybe 150. Their A1C is about 7.5%. Why do we do it right away?
You don't know how long it's been going on.
Because you don't know how long it's been going on. What did I tell you? Onset of disease is how many years before you probably diagnose them? 10 to 15 years. It's been slowly going on. Hadn't been at the same level you're going to see them at, but the process started way before that. So send them, write the note, write the order that day. Okay. And how often should they occur? So a good system, Dean McGee, excellent system, they set you up. If you're seen over there for diabetes with retinopathy screening, they're gonna set you up in 1 year for another appointment, okay? They also, those ophthalmologists will make the call as to when they need to be seen back. If a person has very good blood sugar control, there's no changes in the eye, then they may say, I don't need to see you for 2 years. So if a patient comes back and I say, when are you going back? 2 years. I'm like, great. They could even make the call of 3 years. I've never seen the group over there do 3 years, but I have seen them do 2 years. If they come back and they tell me 6 months, I know that I haven't seen their report yet, but I know that something's going on. Okay. So annual is kind of the benchmark, and that's what you'll be held to. You won't have that many people who it'll only be that'll be every 2 years. It'll be 1 year for most. Type 1, so it differs for children versus adults. So for adults and children 10 and older, 5 years after the onset of diabetes. Again, it's because the complication rate is extremely low. And the likelihood that anything will have occurred or be present is low. So that means if you're diagnosed at age 2, we still don't do anything until age 10, even though that's 5 more years. Get the difference? Okay. So for like Michaela, it's 5 years. Have they sent you yet?
Yeah, I go every year, but my vision's terrible.
Okay. Other reasons.
Yeah.
Okay, and then also annually unless it's progressing or there's a reason to see them more frequently. Pregnancy is a different situation. Pregnancy accelerates retinopathy progression. Okay. So if this is another reason to talk to your women about good pregnancy planning. So if we'd like to know what their eyes are before they conceive. If they already have retinopathy or proliferative, it needs to be addressed, and the ophthalmologist needs to go over with them the risk of a pregnancy and what it can do to their eyes. Okay. So during pregnancy, we want to know before, if we can. During the first trimester is when most of the proliferation will occur. So we want to get them seen during that first trimester. And we're going to have them seen, we may have them seen every trimester. And then they should be seen, postpartum, I don't have it nailed down. For 1 year postpartum, okay. I have not seen that intensive, but I haven't seen that many women with retinopathy during pregnancy. That's the important part to remember, is that it's an acceleration of, it'll be same for kidney. Kidney accelerates. Just remember, what's her name, in Steel Magnolias, what happened to her? She got pregnant, and then what happened? Her kidneys went to pot. Okay, that was true. They did a pretty good job. The renal disease can proliferate or speed up during pregnancy. Okay, so I told you about the less frequent exams, the progression of retinopathy during pregnancy. So treatment. So there is one injectable, I didn't put it down here, it would be done by the ophthalmologist that they can use, but the major treatment is laser. So what they do is they go in and they zap those little blood vessels. And they may do thousands of those little bitty pinpoint, taking out those blood vessels to preserve vision. So that's the treatment, that's the gold standard in terms of treatment. So that's treatment. Prevention, it's blood sugar control. Blood sugar control, blood sugar control. That's one of the motivators to get those blood sugars under good control. Even if retinopathy is present, better blood sugar control can slow that down. There's only one exception to that, is that if they have really poor control and their retinopathy is progressing, getting them under really good control can accelerate that for a short period of time. Then it will stabilize out. But for the most part, I've only seen that happen in 2 or 3 people. So for the most part, Always trying to get blood sugar under the best control will help preserve those eyes, prevention. Okay. So referral. If you see macular edema, if you see severe non-proliferative diabetic retinopathy, get a referral. If you see proliferative diabetic retinopathy, send a referral. The best thing is to get them hooked into a system that will see them, treat them, and keep them ongoing in the system. Dean McGee sends them a note every month, every year, you're due. They set them up before they ever leave. That's a good system. They keep them tracked, they send them reminders. That's a good system. The other thing, okay, Sophia's our diabetes education. So the other thing in diabetes education, what I do is I teach them about this, the importance of them and why we do it and the importance of going to the eye doctor. But the other thing I strive to do in those education classes is I make them advocates for themselves so that they keep track. I give them a little tracker. And some of them are computer literate and they make their own. But it's like you keep track. You keep track. Systems sometimes are good about that. If you have a good EMR system, it may pop up. You see the patient, it says patient's due for their eye exam. But more often than not, things like that get dropped. So I teach them to be good advocates. You remember when you're due for your eye exam. I have no problems with a patient coming in and saying, it's time for my eye exam. If I need a referral, it's time for me to go. With Dean McGee, I don't have to do that, but I do with some of the more local, other solo practice ophthalmologists. But I teach the patients, you keep track of this, you call them or tell me and I'll get the referral written. Okay. Advocacy, advocate for yourself. Patients are usually your best advocates. Okay, nephropathy, yes.
I have more questions about that diabetes education.
Yeah, go ahead.
How often do you see like the same patient over and over? Because you're saying you're like telling them to like advocate, to keep their appointments and stuff. Do you usually have return patients, or is it usually like a one and done thing?
When I was working in the clinic, no, education might be one and done. We had 5 sessions that covered the whole curriculum, so usually they would do that over 1 to 2 months.
Okay.
But in the clinic, then I saw them regularly.
Okay.
So I might see them every month, and as they're stabilizing, I might see them every 3 months, might see them every week. Just depends on how bad their blood sugars were.
I wasn't sure how that would work with like insurance too. Like my dad has type 2. I've never heard of a diabetes educator.
Well.
Yeah.
So with insurance, so we were odd ducks because we had state-supported income. So we didn't have to bill to support ourselves, just our staff and our supplies. So we could bill a level 1, and we could bill for the lab because we did point-of-care testing. So we billed for all of our lipids and our glucose in our A1Cs. So we could do enough to keep. And we had a coag, which was huge volume, which we could bill, and so that kept us afloat. So your dad can advocate for himself. I want to go see a diabetes educator. So most places are going to have them near. Maybe if he lives in a small town, but most hospitals are going to have some kind of. Now, Enid used to have a great system. They had 2 sets, the 2 hospitals, St. Mary's and what's the other one? Integris. But they did, and the only thing is that diabetes education it tends to be get axed early if there's financial difficulty. So they've lost both of their diabetes educator groups, but their county, health department is a very progressive, they're great women, and they have developed a system of support through grants in Enid. And I go up and work with them every month or so. And I visit different physician groups and I educate them about diabetes, and we talk about where they're having problem, and then this group will step in and assist them in their process of care. It's really a good group. I love Enid. They have such neat, progressive thinking people up there. At least that's been my experience. Okay, so nephropathy. Number one cause of people being on dialysis is type 2 diabetes in terms of volume. I think the number one cause is actually hypertension, but in terms of sheer volume, it's type 2 diabetes. So common complication. This is one of those where I told you when we do the ClinMed talk, is that I like to know if their parents were on dialysis. It seems to me that it follows, that if they had a parent on hemodialysis, I tend to see it happen in the subsequent generation. So I really ask a lot of questions about that when it comes up. Let's see. So with nephropathy, blood pressure is really important. That's why we use those ACE inhibitors, because remember, ACE inhibitors work on those efferents, capillaries leaving the Bowman's capsule, and so it decreases resistance in that localized system. And so decreases the amount of protein that occurs in the urine, and it slows down the progression to kidney disease. So that's why the ACE inhibitors tend to be favored in that. So the kidney, that Bowman's capsule, has little pores and little, they call them fenestras, windows, that we can filter toxins out of the urine. Well, what happens, several of your folks that have presented have alluded to this, and Professor Hughes did yesterday. Remember she told you that proteins will bind glucose and become glycated products? When those happen, they don't go away. Those are AGE she was talking about. That's what happens in the kidneys. You get that glycation, you get that destruction, or the basement membrane in the kidney changes structure and it loses function. And those pores also in that Bowman's capsule become larger. So then things like protein start showing up in the urine. That is not a disease in and of itself. It is an indirect signal or sign to you that the kidney is being damaged, it's suffering, it's losing its filtering function. So that's why we watch protein in the urine. It tells us about the health of the kidney. It's nothing to do with the protein itself. It's telling us what's going on with the kidney. So if you look, where did I put that? Oh, well, so normal albumin excretion in a day is less than 30 milligrams per day. When you go work out, if we tested your urine protein, it would be high. Okay? If you're not doing anything during the day, you're not sick, your urine protein will be pretty low. If you're ill, it will go up. If you have another stress event, it will go up. So in the range of 30 to 300 milligrams per day is what we're looking for. That's what we're monitoring these folks that have diabetes to see if we're moving into that range, because that kind of tells us things are happening and that's abnormal. Really significant albumin excretion is above 300 milligrams a day. So on a dipstick, you would get a 1+, 2+ protein in the urine. With that micro, you're probably not going to see it. They used to call it microalbuminuria because it was a small amount. That you won't see on a dipstick necessarily. So we have a special. On the next page, you can see it. It's the urinary creatinine ratio. Oh, what's it called? I'm not telling you. It's the urine albumin to creatinine ratio. Okay. So that normal value is less than 30. Above 30 is abnormal. Now, because it is subjugated to people's activity level or their whether they've been stressed or have an infection, they recommend that you get at least two abnormal in a 6-month period before you call it that. Okay, so usually we don't diagnose it off of one value. So when to screen? So again, type 2 adults, the day you see them, you ought to put that on your lab value, okay? Unless something is going on with them that you think would mess up the results or change the results in some way you think would, you know, like the stress or the UTI would be a time not to do it. And those should be done at least annually if they're normal. For adults and children, again, it's 5 years after onset of diabetes. So risk factors that increase the risk of progression to end-stage renal disease, elevated blood pressure. It's so huge, and once it gets there, you can't reverse it. When you start to see serum creatinine go up, you are about 3 to 5 years from end-stage renal disease. So really important to monitor the blood pressure. Also monitor that albumin or proteinuria. Or glycemic control. Also, I think in the DCCT, it was about a 54% reduction in nephropathy. So it's a significant change. Keep their blood sugars normal and their blood pressure. Smoking, of course. Here, that high dietary intake of protein. Proteins are, I wish Lauren was here, they are solute dense. So when you eat a high protein diet, it's a lot of work for the kidneys to excrete it. That's one of the reasons why we want people to eat a lower protein diet when they have renal, well, I can't say that because we often want their protein to go up because they waste it so much. But high protein intake can be damaging, so getting it back down to normal probably would be the most. I'm a little bit out of my zone in terms of giving you the exact nutrition or dietary, but if they're high protein intake, we usually want them to come down. So what was normal protein intake for an adult?
0.8 to 1.
Say it again?
0.8 to 1.
Yes, 0.8 grams per kilo per day. So ACE inhibitors, ARBs, are the preferred. If patients have proteinuria, then if they have proteinuria with or without high blood pressure, we're going to treat. Okay. ACE inhibitors would be the preferred. Now, if someone has no albuminuria, if it's normal, and you're going to treat high blood pressure, the new recommendations are that any out of the class, and I think I put them down there, on the very last, patients without albuminuria, but you're going to treat their blood pressure, you can use any of those four, a medication of any of those four groups. ACE inhibitor or calcium channel blocker or a thiazide-like diuretic. That's new. But keep in mind who they're saying. It's those without any high albumin excretion. Remember to monitor creatinine. Remember the side effects of ACE inhibitors, ARBs, elevated potassium, right? Serum creatinine goes up, right? Monitor those. So those don't change when you use these drugs. It won't reverse it. You can't reverse that albuminuria. You can just slow down the damage. Okay? So we can't make those little openings tighter again. We can't reduce them, but we can slow down the progression. So it's different. It isn't like you treat them and then you monitor their albuminuria. You can, because you look for worsening, but you won't see a reversal. You may see variations, it may improve, but you're not going to use it as an endpoint. Does that make sense? Like when we treat blood pressure, we treat to an endpoint. We don't treat the albuminuria to an endpoint. We're slowing it down. We would treat the blood pressure to an endpoint. We treat blood sugar to a goal, okay? That's what is indirectly going to help keep those kidneys healthy. The albumin simply tells you is what does the damage, is a product of damage that's being done. So it's like an indirect measure. Let's see. Page 6 is a repeat of things you already know. So adverse effects, hyperkalemia, monitoring the serum creatinine, dry non-productive cough. If that occurs, move them to an ARB. ACE inhibitors, ARBs, you wouldn't use, you can use one of the other agents. So labetalol would be okay to use. You've got the nifedipine, which you could use, that's also indicated for hypertension during pregnancy. Here's what I'm going to do. I'll meet you after lunch, but I'm not going to do the medication history. I'm going to cover this because I need to go over the the foot stuff with you. I also want to go over diabetic foot care because in your note I'm going to have you do, I haven't decided yet, but at least 2 or 3 patient education little lines. I want you to convey that to the patient. So I'll just move medication history taking out, and we'll finish this up and hit the foot well so that you're prepared for tomorrow and then for your SPDL. And then we also have to cover aspirin use, the statins you've already done, and what was the other thing? And the vaccines. So we'll just slow it down. I think I can cover all that in an hour, so if I can meet you back at 1:30. My brain is older, I think I need a break. I'm sure you do, your butts do. And so I'll see you back, let's see, we're gonna start at 2:30. Let's start at 1:20, and then we'll stop and give you a break at 2:20, and then we'll start the phys diet at 2:30. Does that work for everybody? Okay, works for me. All right.